I would like to present on characteristic hospitalized COVID-19 patients in Japan, the insights from COVID-19 Registry, Japan. I'm Dr. Kayoko Hayakawa, National Center for Global Health and Medicine, Tokyo, Japan. I have nothing to disclose. COVID-19 Registry Japan, abbreviated as COVID-JP, is a registry for hospitalized COVID-19 patients. Each healthcare institution participated in the registry on a voluntary basis. Data were manually entered into REDCap case report form using modified ISARIC case report form, enabling to correct original parameters in Japan. The initial inclusion criteria for enrollment are a positive SARS-CoV-2 test and the inpatient treatment at the healthcare facility. The current inclusion criteria requires that patients have to be admitted within 10 days of the symptom onset or positive test results. COVID was launched on March 2, 2020, but data from early 2020 could be entered retrospectively. As of May 2023, more than 85,000 cases from 619 facilities in Japan had been enrolled. Japan has experienced 8 waves of COVID so far. However, since the reporting of all cases ended in September 2022, and the categories under the infectious disease law were changed in May 2023. Only a portion of the number of cases is currently reported. The case fatality rate, which initially exceeded 5%, is now around 0.5% as of May 2023. Approximately 83% of the population has been fully vaccinated to date. I would like to show you an example of the use of coverage data. This is data from the first wave when no vaccine nor effective treatment had yet been established. Epidemiological data had already been published from Western countries and China, but it was thought necessary to confirm whether the situation was exactly the same in Japan. In our cohort, many mildly ill patients were admitted, but those in their 60s and older tended to be more severely ill, requiring oxygen administration or invasive intubation. Regarding comorbidity, the characteristic that certain comorbidities were more common in patients with severe disease was similar to that reported from countries other than Japan. The identified risk factors for severe disease also overlapped with existing reports, such as heart disease, peripheral vascular disease, chronic lung disease, hypertension, diabetes, obesity. However, the frequency of comorbidities was lower than that in patients' cohorts from outside Japan. In particular, the incidence of diabetes and obesity was much lower in our cohort. For example, in our cohort, diabetes is around 17% and obesity was 5.5%. However, the inpatients cohort from the United States, diabetes is close to 30% or even more, and obesity was more than 40%. The overall in-hospital mortality for wave 1 was 7.5% in coverage data. The mortality rate in this study was lower than in previously reported in patients cohort from other countries. The reason for the relatively lower mortality in Japan may be due to factors such as a lower number of comorbid patients. The lack of dramatic increase in the number of patients during the enrollment period may also have contributed to the lower mortality, as mild cases might have been hospitalized under such circumstances. Various types of study using COVID data have been published during these 3 years in 40 peer-reviewed journals and have also been used as a reference for government policymaking. The most frequent types of research was clinical epidemiology research, but also data were used for social epidemiology study, medical treatment study, and also the public use. I would like to show one example of data utilization of COVID. The famous Act 1 study is an RCT that provided important findings of the medical treatment of COVID. A total of 1,062 patients were enrolled, with only a few from Japan and 5% from the Asian region. As I mentioned earlier, the status of clinical epidemiology in Japan, including comorbidities, was found to be different from that in other countries. Therefore, the question remains as to whether the actual results can be directly applied to the Japanese population. On the other hand, it is not realistic to repeat expensive and time-consuming RCTs and intervention studies in Japan, especially during the pandemic. For this reason, we evaluated the effectiveness of remdesivir using data from COVID and found that remdesivir had a lower risk of requiring supplemental oxygen in hospitalized patients. Although the 30-day mortality and in-hospital mortality and the risk of invasive mechanical ventilation introduction were not significantly different between remdesivir and non-remdesivir group. Since COVID-JP invites voluntary participation by institutions, selection bias is inevitable. We also evaluated the representativeness of COVID data compared to national data. COVID-JP represented 1% of total COVID cases according to national data. The proportion was high during the first wave, more than 30%, and tended to decrease, especially after the fourth wave, at least partly due to the termination of funding. Medical facilities were encouraged to participate in COVID when they contacted the ministry to request favipiravir, antiviral drug, and this may have facilitated case registration in the early period. Case fatality rates in COVID tended to be higher than in national data because COVID targets inpatient and national data includes outpatients as well. Current benefit to participating institutions include the return of the institutional data, the ability to propose and conduct research using multi-center data, and the contribution to COVID research and public health. In addition to research, the summarized key data from the COVID is openly available on the internet in a dashboard format so that it can be used by many people. Summary of the advantage and disadvantages of Coverage. As for disadvantages, case registration is a manual process and places a heavy burden on facilities. It is better to have the funding for this reason. Only data listed in CRF can be collected. However, this can be overcome by combining it with a questionnaire, such as in the longer COVID study. Pathogens are not available in coverage, and now selected facilities are moving to combined sampling called rebind system in Japan. Also, the retrospective nature limits the types of studies and data use. As pros, coverage allows collection of detailed real-world clinical data outside of fully controlled conditions, such as RCT. Case report form can be revised to reflect changes in situation, such as available vaccine or drug, while maintaining a balance with data continuity. Using Registry, it is possible to conduct research on different types of questions. Of note, some questions may require high-level statistical analysis, for example, to adjust confounding effects of the patients. So the statistician's help is critical to do such kind of research. Also, we can use existing system REDCap. So I presented the outline of the coverage JP in Japan. Here is my acknowledgement. We thank all the participating facilities for their care of patients and the cooperation on data entry to the registry. Thank you very much for your attention, and thank you for the opportunity for the presentation.